And briefly we would be discussing about little what HICPAC, this is the Hospital Infection Control Practices Advisory Committee, has to say about it. And then universal precautions, and then we will briefly discuss on what are the bases to create further to it the isolation precautions, and their what are the various types of isolation precautions which are based on the transmission, like contact precautions, droplet, and airborne. And then we'll summarize the topic before moving on to the bundle approach. So all this came into picture after HIV pandemic started and the first few cases were reported. Then the term came as universal precautions in the year 1985, which was primarily applied to all blood and body fluid precautions universally to all people. And it also included prevention from needle stick injuries, and it used the certain practices like hand hygiene, traditional barriers like PPE, gloves, overalls, then you can say sharp shift safety, safe injection practices, and it was sterile instruments and devices, and clean and disinfected environmental surfaces. These were the few key points which universal precautions were covering, but it was not applicable to feces and sweat. So as the advancement happened, then another term came, which was like body substance isolation in the year 1987, which was over and above universal precautions. And it was, by definition, isolation of all moist and potentially infectious body substances, which was like blood, which was already covered, urine, saliva, feces, sputum, and other body fluids, regardless of their infectious status. This is the key thing which we need to remember, that any universal precaution or BSI, and maybe we discuss further to it, it is regardless of their infectious status. It is applicable at all times during the patient care. It is not that if somebody is infected or carrying that infection, then only we need to take it. So in 1996, before HICPAC gave isolation precautions, and prior to it, this along with that, the term came standard precautions, which incorporated the best of both the definitions, universal precautions and body substance isolation. So it comprehensively became a standard precautions, though still we use synonymously with universal precautions, and it is a whole gamut of precautions for the infections which are potentially originating from blood or all body fluids, the non-intact skin, mucous membranes. So this is the term which is being now practiced, and the precautions and the what precautions we need to take, like barrier precautions or like clean equipment, like sterile equipment, clean environment. So this all comes under the part of standard precautions. Now will we move slightly towards specialized kind of precautions, which are in certain situations which we encounter. Where, by and large, during any patient care, we have to follow standard precautions. So basis transmission of infection, the three precautions were added over and above standard precautions. In that circumstances, or under these circumstances, we need to follow these, which are like droplet precautions, airborne precautions, and contact precautions. So we'll go through them one by one. So what was isolation precaution? Currently, CDC HICPAC proposed guidelines describing the methods and indications for these precautions are straightforward, but effective barrier at the bedside are sometimes still lacking today. So why we are discussing isolation precaution? Because it has been clearly laid out, but still many of us don't practice in reality. Even the standard precautions are not practiced, then it, and further to it, isolation precautions we need to add to it. So we need to implement on ground. That's the key thing which CDC or HICPAC is still worried about. So the aim is to preventing transmission of infection by means of isolation procedures in a scientific and a cost-effective manner. In 2007, the indications and methods for isolation as described in 1996 were updated, taking into account the changing patterns in healthcare delivery, then emerging and re-emerging of pathogens, and most importantly, additions to the recommendations for standard precautions. So it has been now updated in the year 2007. So classification, we have discussed the basis, which is isolation and barrier precautions aim to reduce or eliminate direct or indirect patient to patient transmission of healthcare associated infections that can occur through three mechanisms. First is contact. We all know about it, which involves skin or mucosa to skin contact and the direct physical transfer of microorganisms from one patient to another or via hands of an healthcare professional or personnel, and indirect via a contaminated surface. So that's why it is being said most of the time it is the healthcare worker, maybe a doctor, maybe a nurse, maybe a staff, supporting staff, or anybody who is taking care of patient usually transmits the infection from one to another patient, which is not carrying that infection. So one is the direct contact and another is indirect contact, which becomes more important in a healthcare setting. Second is via respiratory droplets. What we are facing today in COVID is larger than 5 microliter of droplets, which are not suspended for long in the air, and they usually don't travel a distance of more than 1 meter. That's why we have been talking about do gaj ki duri and things like that. And that's why we need to maintain a physical distance or social distancing. Then coming to the airborne transmission, it is an age-old infection, at least in terms of Indian subcontinent. One of the example we all know is tuberculosis, where the particles are less than 5 micron or equal to 5, remain suspended in the air for prolonged periods, and therefore can travel for longer distances and infect susceptible host several meters away from the source. So the key difference in the respiratory droplets and airborne transmission is the size of the particles and the distance traveled. That's why infection spreading through respiratory droplets, we emphasize on contact tracing. But in case of airborne transmission, it becomes very difficult to trace from where you would have contracted the infection, because it travels several meters and the bacteria and whosoever transmit these kind of infections are quite hardy to survive the environment harshness. So coming to the first one, the simplest one is the contact precautions. What we need to do in addition to the standard is to intend to prevent transmission of infectious agents which are spread by direct or indirect contact with the patient or patient's environment. Also applied where the presence of excessive wound drainage, fecal incontinence, or other discharges from the body suggest an increased potential for extensive environmental contamination and risk of transmission. So contact precautions are essential whenever transmission may occur by skin to skin contact and direct physical transfer of microorganisms. If you are available, if it is available, provide a private room. Otherwise, cohort patients infected with the same microorganism but with no other infection. Non-sterile gloves should be worn before entering the room. Apply hand washing and hand antisepsis as in standard precautions. Do not touch potentially contaminated surfaces or equipment which have been in contact with the patient. Wear a clean, non-sterile gown when entering and remove it before leaving the room. Limit transport of patients to medically necessary purposes. It should not be as and when it is going and getting in contact with the surfaces, and from there the infection is being transmitted to other set of patients. And while transport, if it is necessary at all for any medical reasons, it all times maintain isolation precautions during transport. That is more of barrier precautions. When possible, limit the use of patient care equipment to a single patient. These are few of the areas where we apply this. Standard is slightly mentioned over on the top of it. It is for all the patient, irrespective of the infectious status. Contact, where the infection is likely to transmit from skin to skin, mucosa to mucosa, or indirect contact. Infections, like during the procedure, during the abscess drainage, bronchiolitis, conjunctivitis, gastroenteritis, where diarrhea is happening, hepatitis. So these are all entire list. You can just go through it. And scabies and any skin disorder. So coming to the next one is the droplet precautions, which are intended to prevent transmission of pathogens spread through close respiratory or mucous membrane contact with respiratory secretions. Because these pathogens do not remain infectious over long distances in a healthcare facility, so that's why we don't need special air handling and ventilation to prevent droplet transmission. So what we need is provide a private room, excuse me, or maintain spatial separation of at least 1 meter between the infected patient and other patients and visitors. Patients with excessive cough and sputum production should receive a single room first. Special ventilation is unnecessary and the door may remain open. So masks are worn within 1 meter or 3 feet of the patient. And limit transport of patients to medically necessary purposes and maintain isolation precautions during transport, means the droplet. And when possible, limit the use of patient care equipment to a single patient. So that's what we are today following, that we are maintaining distance, we are wearing mask while handling patient or while going outside. And that's how we are maintaining a droplet precautions to save ourselves from getting the COVID-19 infection. So this is one example which is prevailing. The pandemic is going on, so it is easy to understand in this regard. So these are the infections for which it was being followed and it is being followed, which is like influenza virus, mumps, pertussis, pneumonia, rubella, and viral hemorrhagic fevers. Now coming to airborne precautions, which prevent transmission of infectious agents that remain infectious over long distances when suspended in the air. Most common we have been hearing is Mycobacterium tuberculosis. Another is chickenpox or varicella virus. The preferred placement for patients who require airborne precaution is an airborne infection isolation room. So that's why any TB hospital, you say it is AIR room, which is a negative pressure room, needs to be in place for taking care of such patients. So therefore, susceptible healthcare personnel are restricted from entering the rooms of patients known or suspected to have measles, varicella, zoster, smallpox, or TB. As for other infections requiring airborne precautions, patients with suspected or known infection by TB should be nursed in a private room where the air flows in the direction from the hall into the room with 6 to 12 air changes per hour and appropriate discharge of air outdoors. Appropriate discharge means that you need to treat the air with the help of HEPA filter or burners, whichever is the practice, which most common is HEPA nowadays, which it should not contaminate the air itself. So air needs to be flown from outside to inside to outside, not from room to outside. That's why it is AIR room. High efficiency filtration, the HEPA filter is necessary if the air is circulated in other areas of the hospital. Keep the door closed at all times until unless required, or you can have an entire room. Cohorting can be done in rare circumstances for patients infected with strains presenting with an identical antimicrobial susceptibility. That is very important. So you cannot put a susceptible to a anti-tubercular drugs with a MDR patient. So then automatically the patient who is recovering with the anti-tubercular drugs, which will get an MDR infection for sure. So that needs to be kept at all times, that you cannot just cohort basis the positivity or the similar kind of infection. We need to look from the anti-tubercular drug susceptibility as well. So respiratory protection must be worn by both healthcare personnel and visitors whenever entering the room, and for obvious reasons, it is understandable the entries should be limited and very much restricted. So we have already covered this part of it. To summarize, standard precaution combines the major features of universal precautions and body substance isolation and are based on the principle that all blood, body fluid secretions, excretions, except sweat, non-intact skin and mucous membranes may contain transmissible infectious agents. Transmission-based precautions are based on routes like contact, respiratory droplets, and airborne. Droplet precautions are applied for patients infected with pathogens that is spread by respiratory droplets larger than 5 micron. Airborne precautions are applied for patients infected with pathogens spread by respiratory droplets which are equal to or lesser than 5 micron meters. So thank you. So if everybody is okay, we can move to the next, which is the bundle approach, which is related to this topic only. So what I have tried to do in this presentation is, before we move ahead, is that I have taken an example of ventilator associated pneumonia, and we'll try to emphasize why these bundle approach came into picture and what is actually bundle here means. And it is more of it's a good thing to happen. Earlier there was a conventional set of management, and it was a predefined management which usually being practiced by healthcare personnel. Now it is more of an evidence based, and it has certain criteria, how these evidences are being substantiated, which I will also cover in this topic. So this will help you to design the bundle of your own in your own healthcare facility, and you can take a step-by-step approach. Bundle is not only applicable to just for the treatment. You can have a in toto approach that maybe, for example, you have to change some engineering aspects of it, maybe small management aspects of the patient, or treatment aspect that we will cover in the VAP, and how VAP bundles being proposed, and what are the prerequisites in your setup, and what is not being practiced. You can adopt this and you can practice, and then you can have your own data and look at what has been changed, or whether it has been actually helpful to you or not. So moving forward. So we will cover the little bit of background. Then we will also discuss about VAE, which is now VAP has been little more of a clinical definition. Now, from a surveillance perspective, it has become ventilator-associated events. We will discuss briefly, touch base upon algorithm for better understanding of the bundle approach. And we will also touch on the grading of quality of evidence, how these bundles have been formulated and has been put into practice, or the components of the bundle. So just to brief about the VAP, though it was not part of the topic, I just took as background to a little bit more elaborative on it. The true incidence of VAP is difficult to determine since surveillance definitions are subjective and non-specific. So this is one part that we have been emphasizing to all healthcare practitioners for long, and that we need to adopt standard definitions across which has been proposed by CDC. And unless until your definitions are standardized, your data cannot be compared to the peer group, and you cannot improvise with the national or international standards. So historically, it has been 10 to 20% of all ventilated patients have developed VAP. Strategies to prevent VAP and other VAEs. We will discuss VAE definitions include criteria for ventilator-associated conditions, infection-related ventilator-associated complications, and then possible pneumonia. So what is VAE? Just to make you little simplify at this juncture only, that before actually clinically we say VAP has settled in, these are some observations which during the course of the patient, before he fully manifests the symptoms of VAP, these are some events or some changes happening at all levels, clinical as well as the ventilator level, the oxygen consumption and the cultures. So that gives quite an indication. So that's why these are strictly surveillance definition rather than your clinical. They are not meant for management purpose. And therein you apply a bundle approach at this juncture or prior, the moment the patient is ventilated. So that will be helpful to reduce the incidences of your VAP. Approximately 5 to 10% of mechanically ventilated patients develop VAEs, and obvious reasons mortality can be as high as 70%. What was the traditional definition of healthcare associated pneumonia? It was any patient who was hospitalized in an acute care hospital for more than 2 days within 90 days of the infection, resided in a nursing home or long-term care facility, received some kind of an antibiotic therapy in the past 30 days, and attended a hospital or hemodialysis clinic. This definition was lately removed by IDSA guidelines from 2016 itself. So VAP is like what? A pneumonia where the patient is on a mechanical ventilation. It has to be a mechanical ventilation for more than 2 calendar days on and date of event, with date of ventilator placement being day 1. And the ventilator was in place on the date of event or the day before. So VAP is usually defined by clinical and microbiological criteria, and microbiological criteria is mandatory to complete the definition. It's not mere the clinical. You need to have an evidence of the presence of an organism, which is like worsening oxygenation, high temperature more than 38, or hypothermia, and counts more than 12,000 or less than 4,000. And in microscopy, it shows a purulent respiratory secretion and positive microbiology culture of either sputum, aspirate, bronchoalveolar lavage, lung tissue, protective specimen brush. It depends. And it has to be a mechanical ventilation, not a CPAP or things like that. The weakness of traditional VAP surveillance definitions limit their utility for measuring the impact of care improvement programs. So that was the problem, because once you the infection fully settles in, then in any improvement program becomes little meaningless, because now you have to manage the patient, you have to manage the event which has already happened. So that's why the definitions were changed and we have moved to VAE, where you can set up your benchmarks and you can put a bundle approach or put certain practices in place where that's how you can reduce the incidence of VAP. So these the definitions were given by CDC. So these are different types of CPIS score which is being followed in CDC based definition, at least one criteria. This I will cover in a different chart. So how this progresses to VAC to IVAC, then the PVAP, probable or possible VAP. So VAC, when FiO2 is more than or equal to 0.2 sustained for 2 days, or 2 or equal to 2 days, and in case of PEEP values of 3 centimeter or more of water sustained for 2 days, which is a pressure. So in that case, we call it as a typical of that it is likely a ventilator associated complication settling in. So when it progresses to further, then there are clinical criteria which we have mentioned, and then the antimicrobial, the microbial agent also comes into picture. And possible VPAP, we practically isolate the organism from any of these samples which we discussed, and then it becomes almost certain that this is, and once the entire definition of VAP is satisfied, it is labeled that the patient is suffering from pneumonia now. So fractionation of oxygenation, if it is more than or 0.2, means the patient requirement is on a higher side for continuous 48 hours, then likely that the patient is going into VA ventilator associated complications. And similarly, if it's positive and expiratory pressure is also on the higher side, so we can deduce these conclusions that we need to make certain efforts to prevent the incidence of settling VAP. So this we have discussed, and this is the algorithm, and it is taken from the CDC. So patient has a baseline period of stability or improvement on the ventilator defined by more than or 2 calendar days of stable or decreasing daily minimum FiO2 or PEP values. That should be the ideal thing which we would expect. The baseline period is defined as the 2 calendar days immediately preceding the first day of increased daily minimum PEP or FiO2. After a period of stability or improvement, the patient has at least one of the following indicators: whether the FiO2 it's more than 20 points, or PEP value is more than or equal to 3 centimeter. So that if any of these two condition is present, then the patient is going into VAC. Now after VAC, on or after the third day, we have already entered of mechanical ventilation, and within 2 calendar days, before or after the onset of worsening oxygenation, the patient meets both the following criteria: is high rise in temperature or hypothermia, and a new agent started coming in, or you have to add an antimicrobial agent to it. So these are the criteria which we can discuss in detail. After this, once IVAC we have started, then we get a positive culture from any of the samples like endotracheal aspirate, bronchoalveolar lavage, and these are the colony forming units which are mentioned. Then another criteria that you see in high power field, then it is a purulent respiratory secretion. And one of the following tests which are positive, there are organism identified from thoracocentesis of pleural fluid. Then histopathology also shows evidence of infection, and if a Legionella has come up. So these are certain things which now clearly indicates that we are moving towards VAP. So how to prevent it? So interventions that improve objective outcomes with little risk or harm are classified as basic practices that are suitable for all hospitals. So that's how the bundle come in picture. The bundle is a structured way of improving the process of care. It is not a particular thing that you are putting antibiotic or you're putting IV lines, you are changing something, you're monitoring something. It is the entire process of care. It has an impact on the process of care, be it right from your hand hygiene to the level of actual treatment which is going or imparted to the patient. And patient outcomes, a small straightforward set of evidence-based practices which I have been emphasizing, and they are generally 3 to 5 depending on your setup, and that when performed collectively and reliably, because everyone has to play a role, It will be a multi-model team, you can say, which will be doing these different activities and have been proven to improve patient outcomes. So how they have been graded, these are the 3 grades, because it is a quality, that's why I put it across this also, that high, moderate and low. So highly confident that true effect lies close to that of the estimated size and direction of the effect. Evidence is rated as high quality when there is a wide range of studies with no major limitations. So majority of studies are in sync, and they are saying that if we apply this change in a process of care, that is, it is going to make a change. It is going to bring better outcome. So it becomes a high quality. Moderate, obviously a slightly lower degree to it, that there are many studies, and but there is a possibility that it is substantially different. Evidence is rated as moderate quality when there are only few studies and some have limited limitations, but not major flaws. So then comes to the low. The true effect may be substantially different from estimated size and direction of the effect. Evidence is rated as low quality when supporting studies have major flaws. Means there are various studies which says, some 1 or 2 says, okay, fine, this data is varying from say 0 to 100% of it. So in that case, the evidence becomes low. And generally, we don't adopt such quality of evidence in our actual practices. And if at all you want to practice, then you had to have your own committee. And if there is a consensus, if there is something which we need to give it to the patient because there is no other option left, then we go for it. So that is an internal call of your health infection control committee, or maybe the healthcare committee in your own setup, healthcare setup. So like few of the strategies we will discuss what is being applied, like avoid intubation if possible, if we at all possible, that it can be supported on non-invasive ventilation process. So obviously this will be the best way to prevent, but if it is unavoidable, okay, fine. But at times what happens, it is being treatment is generally overdone. So that's why the emphasis is on the fact that as long as possible, prevent, not to avoid, not to do intubation or put up the patient on mechanical ventilation. Then minimize sedation, because you can easily manage ventilated patients without sedatives whenever possible. And the quality of evidence is to preferentially use agents and strategies other than benzodiazepines to manage agitation, such as analgesic for patients in pain, reassurance, antipsychotics. So basically, obviously, the aspiration chances are reduced. Then there are practices, if you have to sedate, if you can interrupt, there are spontaneous awakening trials for patients if there is no contraindication. So this method can also prevent the settling in of ventilator associated complications. Then you should actively assess the need of extubation once a day. So spontaneous breathing trials you can, so it is more, if you can see, it is more on the fact that you try to wean off the patient as much as quickly as possible. It's not that you should put the mechanical ventilation or intubate and forget about it. Okay, fine, we'll do it on our at some particular time. So pair spontaneous breathing trials with spontaneous awakening trials, which we discussed, and this is a quality of evidence is grade 1. So it's a high quality evidence. Then maintain and improve physical conditioning like exercise and slight bit of mobilization of patient if possible. Then avoid pooling of secretions into the above the endotracheal tube cuff. Like you can take out the subglottic secretion from drainage ports, 48 to 70. So the aspiration will be less and things like that will prevent. You can also do the elevate the head of the bend, which is not so good, that good evidence. Then you can maintain the ventilator circuit for as long as possible. It's not advisable to change ventilator circuit quite often unless until it is visibly soiled or it's not functioning well. So you can see this is a straightaway guidelines which I presented, and there are multiple evidences mentioning over here, and they're high, moderate, and low evidence. You can see on the extreme right of it, and then you can go for certain special approaches also, like selective oral or digestive decontamination, because gastric or the oral infection can also lead to travel through lungs, like regular oral care with chlorhexidine, prophylactic probiotics, and things like that. these are few things which have been practiced and over practiced, like silver coated and antibiotic coated tubes and all, which have not been generally recommended by the committees. So this is one of the bundle approach, and you can see these are 5-6 approaches where we have discussed few of them. Another, we can do some peptic ulcer disease prophylaxis because a lot of antibiotics and it is already intubated. Then patient is lying for so long, so we do a DVT prophylaxis and daily oral care with chlorhexidine. So post ventilation or maybe the patient recovers should not go into these kind of complications as well. So these are all evidence based, and this is entire process of care which has been impacted by the bundle approach, and these are targeted intervention. This way, if you have designed and you have put in across, and you can do one bit of it instead of putting too many things on your table, you can put 1 or 2 3 changes in your process, and you can keep on monitoring, and maybe you can have a data to present that okay, fine, this is the outcome, how we have improved from the previous outcome, and now what is our better outcome, how many patients have survived, how many patients were not actually intubated, and what were the ventilation days, and things like that can help you to assess your quality indicators of infection control. To summarize, VAP always remains a challenge. So chest X-ray is not included in criteria, and the bundle of interventions for the prevention of VAP aims to highlight interventions which, if implemented consistently, could reduce VAP rates. The quality of evidence. So that's all from my end. And thank you for your patient hearing. So if there are questions related to these topics, you're most welcome.
Thank you, Dr. Anvo, for beautiful sessions. I
you.
think there is no question to this.
Yeah, either they haven't understood or I was not able to make them understand.
No, both days.
Or they have been too tired the entire.
So participants, if you have still any questions, so you can
You can
ask
put
to
in
the
your chat box. It's not that if it should be
yeah,
right.
yeah, correct. Agree.
Okay, then let's take over the part we had given as a pre-workshop questionnaire. Thank you, Dr. Anubhav.
Thank you, sir.
Thank you, sir. Thank you.
We would now move on to
waste management, sir.
oh yeah, sorry, you had waste management.
Yes, sir. So I will take that also.
Yeah.
Continuation.
Go ahead.
Sir.
Go
Okay,
ahead.
sir.
Take waste management.
Thank you, sir. So coming to the topic, which is very common, we practice in day-to-day our healthcare setting once we immediately enter into it. And but what happens, we know everything, but we somehow don't practice anything. And that is not applicable to any of the anyone. It is applicable to all the healthcare professional, and it is the most unattended practices, and it is always taken for granted. It is not only as an impact during the patient care, but it has also after effects into the society, and some certain data I've tried to capture also, which will be was a little eye opener for me as well. That and so much so it has been ignored by the government officials, and there is no will to implement in a big way, because now few years back only I've been hearing in Delhi NCR that it will be applicable to, it has already started to smaller clinics, nursing homes, and to an extent even still we have no policies or no ways to dispose the biomedical waste which is being generated at household level as well, because we do have certain things happening at our home as well by the local physician, and we just put it in our common dustbin or a waste bin which we are using in our kitchen. So to that extent it is being ignored, and but nevertheless it is a very, very important topic, and it sounds really easy and for all of us because we know everything, but the only problem is that the ground reality is far different, and it is left over to the housekeeping or the what you can say, the morale of the housekeeping person or the ethics of him that he needs to practice. But as a healthcare workers, we ignore everything, and that's what I would try to emphasize, that how we should bring in and revive this particular thing and start doing if we have been not doing till now. So what is the present scenario of this is today's is like actually India generates close to these much kgs of biomedical waste, which is like 4,05,000, of which 2,91,000 is disposed, means almost 28% left untreated. Nobody knows where it goes. And in terms of quantum of waste generated, Karnataka tops with Uttar Pradesh and Maharashtra and Kerala come close. So it's a huge waste, which is a quantum of waste which is generated across the nation. Forget about global data and all. And this extend to that, and it has an impact to the society to the extent that UN Human Rights Council special report of 2011 mentions that improper management of healthcare waste leads to violation of right to life in terms of deprivation of right to clean air, water, and environment. So we have been impacting so much so to the ecosystem around us, which we knowingly or unknowingly putting it, especially the healthcare waste, which it is hardly 10 to 15% of waste which is totally generated, but still it is an eye opener that for the human, that UN United Nations, that he has to bring in the term right to life, because it is an infectious waste. It needs to be segregated, processed, and then dumped at the appropriate sites which are being targeted. So if you can see, the worldwide 5.2 million people die because of these wrong practices or wrong disposal of or unprocessed biomedical waste, and of them 4 million children die from waste related diseases. So it's an alarming data, and we should little bit put attention across this. So just to broadly classify, biomedical waste is a non-hazardous waste which is maximum in quantum 75 to 90%, and the hazardous waste is 10 to 25, which is again classified into infectious and other hazardous waste. So it primarily focus on the infectious part of it, and these are the specialized waste which we generate in certain units, right? Radioactive waste, the gases, glass, then the containers, the different types of gases, and chemical, cytotoxic drug waste, and incinerator ash. So what is biomedical waste? Means any waste generated during the diagnosis, treatment, or immunization, like today is going on. You can imagine what amount of waste is being generated across the globe because of just COVID-19 immunization. Though we are saying it is not up to the mark. Of human beings or animals, or in research activities pertaining thereto, or in the production or testing biologicals, including the categories mentioned in Schedule 1 to these rules. So you just limit to the definition. Schedule 1 is the gazette term which has come from Biomedical Waste Gazette notification from Government of India. Any waste during even the diagnosis, treatment, or immunization of human beings or animals, and in research activities as well, encompasses and includes whatever is generated under the definition of biomedical waste. So I just want to briefly highlight on the part of the occupier and operator. Who is the occupier? Person having administrative control over the institution. Means if you are running your own hospital, nursing home, healthcare facility, or any lab or any whatever it is, where research facility, and the premises generating biomedical waste, which includes a hospital, nursing home, clinic, dispensary, animal house, pathology lab, blood bank, healthcare, anything you do a healthcare related activity makes us an occupier. Operator, person who owns or controls or operates a common facility for the collection, reception, storage, transport, treatment, disposal, or any other form of handling of biomedical waste. So you have been, you might have encountered that earlier occupier and operator were more or less same. Means the institutions, bigger institutions have their own incinerators and things like that. Now the rule has come up that anything within the 75 kilometers of the occupier or the clinic or hospital, they need to connect to the certified agency, which is the operator, and has been licensed to handle the biomedical waste and dispose it. Needs to be have a contract or agreement like thing, and he is the one who is going to dispose it of. Our role is limited, and we will briefly touch upon that. What is our role in terms of administration? Before, after talking all about what is a type of waste, what are the categories of waste and all that. So what are the duties that we will touch little later? So what are the basic elements that you need to designate the infectious waste? We need to identify what is infectious, what is hazardous, what is non-hazardous. Then waste discard and waste containers, we all know. Collection, handling and movement of waste within the institution. Means collection means whenever you are collecting, you are trying to segregate at source itself. How you handle, how you package, and how you move the waste from one place to the common storage facility from there. The disposing agency will pick it up. Then how will you store in your on-site, because you can store it up to 48 hours. Then disposal of untreated infectious waste. Then waste treatment and disposal of treated waste. These are all basic components which comes into waste, biomedical waste management in general. So these are the few categories I will highlight from the previous guideline. Then we will move to the new version where the categories have been now limited to 8 only. So category 1 is human anatomical waste. Category 2 is animal waste. You can see on the right side, we are talking about the methods of disposal, incineration, then deep burial. Then category 3 is microbiological waste, which are infectious waste and biotechnology waste, which are generated through the vaccine development and cell cultures and things like that. These are generally disinfected at source itself. Every microbiology lab does do so, and then primarily with the help of autoclaving, and then they are discarded. And discarded in the sense they are stored, and the common facility operator takes it up, and then he further disposes of. So then coming to the category 4, 5, discard. Then syringes, the sharps category fall into category 4. Then 5 is discarded medicine and cytotoxic drugs. Then 6 is your solid waste, and category 7 is your solid waste, which includes more of tubing, catheters, and intravenous sets. And category 8 is the liquid waste. You don't need to mug it up. It is all mentioned on the chart, and it is being aligned that way. The only thing you need to know where to put waste. That's why the trainings are very important, and on-site training is very important. And each one should train each other on a day-to-day basis. Category 9 is the incineration. As after the entire waste is being disposed in the incinerator, there is a lot of ash is produced. This is used in the landfills. Then the last is the chemical waste used in production of biological chemicals, used in disinfection like hypochlorite and things like that. And they are treated through ETP plants and all. So category basis, it is yellow bag 1, 2, 3, 6, the anatomical waste, and then you can see the second category was like animal waste, and microbiological waste, and the solid waste like dressing, soil, cottons, and all. Then red bag, and this varies from your geographical continent slightly. The color, it's blue, white, puncture proof. Then black is for general waste. We all know about it. Now it is being replaced by a green in practice. So it is like biodegradable bags which has come up. So these advancements are happening. So this is how the things have changed. Then every occupier generating in 11, the new notification came. Then irrespective of the quantum of waste, comes under the BMW rules and requires to obtain authorization. Now it is not limited to the number of beds. Everybody who is generating, even if you have a 1 bed, you come under the prerogative of that. Then duties were clearly defined of the operator. Then categories of biomedical waste were reduced to 8 from 10. Certain things were clubbed. Then treatment and disposal of biomedical waste made mandatory for all the healthcare institutions. Then a format for annual report was there. Form 6, that is the report of operator on HCE, is not handing over the BMW, added to the rules. So these are some you can say administrative controls were there. Even now in 2018, the updation with the bar-coded bags have come up, that you need to keep a track, the weight, and everything is being now modified to make it more and more compliant, and more you can then penalize the operator / occupier, whosoever is not following the guideline, because it has become a big problem for the entire human race itself. So 2011 discarded category 8 containing liquid waste from laboratory cleaning, washing and disinfection, and category 9 containing incineration as. Laboratory waste in category 8 were included in category 3 itself and cleared the confusion regarding disposal of 3 and 6, which could either be disposed in yellow or red colored bags. So they also incorporated storage and disposal of municipal solid waste generated from hospitals, which was mostly the general waste. So this is how it being modified. You can have a look in the Gazette notification, and you must be all aware as well because you are in practice. And this is how the yellow bag is usually go into incineration, red is being autoclaved, and then puncture proof are being crushed, and then blue are non-fluorinated bags. To summarize, the proper management of biomedical waste is a concern that is recognized both by government and non-government agencies. Guidelines for disposal of blood bags, pressurized container, all to be incorporated in the rules. Then raising awareness of risk. Every healthcare facility must select safe and environment-friendly management options to protect people from hazards during handling of waste. So how to prevent all of us from that? That's why we just to understand that the administrator who has the onus to run that healthcare facility, you can be an independent person as well, that it is being handled without any adverse effect to human health and environment. That is the responsibility, and that's how we prevent ourselves as well. Then you need to provide all the training key personals which are involved in handling the biomedical waste, be it a generator, be it a transferring person, be it the person who is carrying your waste, and at least 1 year thereafter. Then the which infections are preventable, like from needle stick injuries or maybe sharp objects. You need to immunize the healthcare workers through hepatitis B and tetanus, and if they are working in certain facilities like in tuberculosis and all, they should undergo also chest X-ray and things like that as a preventive health checkup to ensure that they are in good shape at all times. Then ensure segregation at point of generation. It is now being emphasized again and again, and it is more or less now practiced also, that all the bins are there, proper bags are being put every day. They should be only 3/4 full. They should be properly tied. Waste should be segregated at source, means that you put the right thing into the right bag only. And you ensure occupational safety by using all barrier precautions, and it should be available for the housekeeping staff also. Generally they are not provided with puncture proof gloves and things like that, and their health checkup should also be performed because they are the one who handles maximum of it, and they are the one who suffers maximum of it. So this is in brief, and I have not tried to go into more of a theoretical aspect of it, which we all know. It's more on the emphasis on the practices which we need to inculcate, and we must be doing, but we would be missing on something, and we should emphasize and implement on ground and try to educate each other rather than waiting for the event to happen. So this was one statement which I picked and would like to share. Let the wastes of the sick not contaminate the lives of the healthy. So that's our objective. And with this, I would like to close my talk and over to sir.
Thank you. Thank you, Anubhav.
Thank you, sir.
We'll have 5 minutes break and then we will restart.
Okay, sir. Thanks a lot, sir, for giving me the opportunity, and 360-degree as well. So we would like to have more interactions if given the chance.
All right.
Thank you, sir. Bye.
Thank you. So 5 minutes break and then we start in 5 minutes. That means 3:07 we'll start.
Okay, sir. Fine.
Okay, let's get back then. And we will now, are we back? Is there somebody missing?
Yes, sir.
Are we all back, or some people have dropped out?
Only two people are, sir. They have some emergency in family, some death history.
Okay. All right. Then in that
Yes.
case,
Yes.
let's start with core concept for hand hygiene and clean hands for healthcare personnel, which, as you know, is very important part in hospital infection control. The learning objectives are outline the importance of effective hand hygiene for protection of healthcare personnel and patients, and describe proper hand hygiene technique, including when various techniques should be used. Now, why hand hygiene is important, that should be very clear to us. The microbes that cause health-associated infections can be transmitted on the hands of healthcare personnel. Hand hygiene is one of the most important ways to prevent the spread of infection. Too often, healthcare personnel do not clean their hands. In fact, missed opportunities for hand hygiene can be as high as 50%. Even in developed countries, 1 out of every 25 patients has a healthcare infection. In developing countries like India, this is more frequently, even 1 in 10. And environment surfaces can look clean, but bacteria can survive for days on patient care equipment and other surfaces like bed rail, IV pump, etc. It is important to use hand hygiene after touching these surfaces and at exit, even if you only touched environmental surfaces. Hands would help make multi-drug resistant organism mobile. Healthcare associated infections are caused by Staph aureus, by E. coli, by Pseudomonas, by Enterococcus, and Clostridia difficile. And these can be moved from one place to another, from one person to the other person by the hands of healthcare workers. Therefore, WHO has suggested there should be at least 5 times that the healthcare worker should wash the hands. And the 5 moments which have now been adapted by everybody in healthcare settings is: 1, before touching a patient. Before touching a patient, you should wash your hands. Before providing a clean aseptic procedure, we should we should wash our hands. So these 2 are to safeguard the patient. Before touching a patient, we should wash our hands to safeguard the patient. Before providing a clean aseptic procedure to the patient, we should wash our hands. This is again to save the patient. But the next 3 are to safeguard us. After direct contact with body fluids of the patient, we should wash our hands. This is after the direct contact. After touching a patient, we should wash our hands because we might have acquired multi-drug resistant bacteria from them. And after touching surfaces around a patient, we should wash our hand. This again is to safeguard our health. So hand washing is a very important step for infection control, but 2 moments, that is before touching a patient and before providing clean or aseptic procedure, this is to safeguard the patient. But 3 moments, that is after direct contact with body fluid, after touching patient, and after touching surfaces around the patient, are to prevent our hands being contaminated with multi-drug resistant bacteria and for safeguarding our health. And of course, if we do not safeguard our own health, then we will transmit infection to other patients also. We should partner with patients for hand hygiene. Healthcare personnel should encourage patients, families, and visitors to clean their hands. Moments for patients to perform hand hygiene are before and after touching invasive devices or bandages, IV, surgical site, feeding tube, etc. They should wash, even patients can infect themselves. Normally, this has been noticed that if the patient carries staph aureus in the nose and after coronary artery bypass surgery, when he keeps on looking at his dressing to see whether he's healed or not, he can cause infection. He can transfer the bacteria from his nose to his skin. After touching bed rails, bedside tables, remote control, etc., patients or patient's relative should wash their hands. Before touching nose, eyes, and mouth of the patient, again, they should wash their hands. Patients should also wash their hand before eating, after touching doorknobs, after using restroom, etc., after blowing nose or coughing or sneezing, before and after changing bandages. So we should also empower patients to speak up, encourage patients to not be afraid to use their voice, that it's okay not to ask their healthcare providers questions such as, I didn't see you clean your hands when you came in. Would you mind cleaning them again before you examine me? Or I'm worried about germs spreading in the hospital. Would you please clean your hands once more before you start my treatment? To implement this, most of the hospitals have now placed hand rubs at the bedside of the patient, so that this encourages the physician as well as persons accompanying them to clean their hands and to use these 5 moments for cleaning their hands. There are various methods available. Hand hygiene applies to use of either alcohol-based hand rub or the use of soap and water. Specific methods include alcohol-based hand rub, rubbing hands with an alcohol-containing hand hygiene product. Second is hand washing, washing hands with plain water and soap, antiseptic hand washing, or surgical hand washing.
Washing should take you about 1 minute. Use a timer or count from 1 to 10 in each of the following steps. Wet hands with water and apply enough soap to cover all surfaces of the hands. Let the water run smoothly to avoid touching the tap later on. Rub hands palm to palm to obtain a good quantity of foam. Then rub right palm over the back of left hand with interlaced fingers and vice versa. Rub again palm to palm with fingers interlaced. Rub the back of your fingers to opposing palms with fingers interlocked, repeating this action for each hand. Rub rotationally left thumb clasped in right palm and vice versa. In the tips of the fingers, rub rotationally backwards and forwards with clasped fingers of right hand in left palm and vice versa. Rinse hands thoroughly with running water. Dry hands thoroughly with a single-use towel. If the tap is not elbow operated, use this towel to turn off the tap without touching it directly. Your hands are now clean and safe.
Okay, if you are asking yourself which method is better, you would find that alcohol-based hand rub is the best method available. One, it will save time because it is effective in 20 seconds rather than the 2 minutes you will take in washing with soap and water. Second, it can be convenient. So one is the effectiveness, second is the time. Can you mute yourself? Okay, so
ठीक लगी सब्जी सब्जी
हाँ सब्जी बढ़िया है मसाला
जस्ट प्याज का बनाया था प्याज है
so alcohol,
मसाला नहीं मसाला डाल नहीं
प्याज लहसुन बस अदरक
ऐसे
ये अच्छा होगा
so what are the benefits of alcohol-based rub? It is, requires less time, more effective than washing with soap and water, more accessible than sink, and reduces bacterial count on hands, and improves skin condition. You should you would prepare. Can you mute yourself?
हम लोग मटर पनीर छोड़ दिए हाँ सास बहू को सास बहू खा ली अच्छा खाना कैसा बहू को खिला रही क्योंकि बहू ने सास को खिला दिया प्याज थोड़ा सा तो है ले लो वहीं से
आगावाला पडदा कहाँ ले ले वो कोई जाए
Aibu.
Hello.
Please mute yourself. Okay, so you see that when you, if you put your,
Hello. 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 Am I audible, sir?
yes, you're audible, then that's why there's a lot of background noise coming.
Okay. Okay. Sorry, sir.
So if you ask the person to push their hand onto an agar plate, you'd find that there are plenty of bacteria present after they've done some ungloved abdominal examination. And the moment you clean it up with alcohol rub, all the bacteria will grow away. And you'll be able to demonstrate after overnight culture how the difference in bacterial load occurs. And as you see, the left hand can contaminate if it touches anything, while the right hand has been decontaminated with alcohol rub. Choosing the right alcohol rub is also important. The hand rub, whether foam or gel, select an alcohol-based hand rub that is between 60% and 90% alcohol. Apply sufficient to palm of one hand and rub the fingers together as you saw in the demonstration. How much alcohol rub has been used can also be used as an indicator that how many times the hands would be washed, because it normally takes about 5 ml of hand rub, alcohol hand rub, to wash the hands. So you can see whether sufficient has been used for decontamination. Hand washing technique you have already seen the video, so you should use that. The myths about hand washing is that fingernails are not cleaned, thumb is not cleaned, and between fingers might have infection. So you should encourage all healthcare workers to wash their hands as frequently as the moment indicate. And monitoring of hand hygiene adherence must be one of the first steps that you can do. One is adherence means how many actions they have taken, how many times they have washed, and how many opportunities were there, multiplied by 100. Define opportunities you will audit before room entry or patient contact, or between clean and dirty tasks, which is difficult to audit, or after patient contact or upon room exit. So you can first define that before touching the patients, how many opportunities are there and how many times it has been used, or after touching patients, how many times they have washed their hands and gone out. Now, monitoring tool, there are many monitoring tools which are available for washing to see whether direct observation is one. It is an educational event, and infection control nurses, after they see a patient, a healthcare worker not washing their hand, should educate about how it has to be done. But normally it is covered that you observe without exposing yourself that who's doing the monitoring. And there are other methods available to monitor whether a hand has been washed or not. The direct measurement methods are covert observation. This is secrets of shopper. Training and standardized tools are necessary to make sure that you get reliable results. covert observation, that means we are clearly observing somebody wash, should be used as a coaching component. And it could be technology assisted. A video monitoring could be there, and that you can then review, or automated system with wearable devices eliminates selection and observation bias, can provide just-in-time reminders to wash their hands. The problem with the monitoring is that there is no accepted standard for number of observations. Normally, many hospitals use 30 or more observations per month per unit, and they can include data separated by role type and can include data by shifts. Many include documentation of contributing factor for failure, especially when infections occur. But normally they should have a checklist which could be then tick marked so that you can evaluate how many times the hand has been washed. Then data is shared, but you should be careful that you should not point out any one person, because that person then will take offense and would not follow your advice thereafter. So the aim should be to talk in percentages, to encourage persons to wash their hands, to remind them if possible, but not to shame them. The aim should be that we should then share the data that how hand hygiene has improved, how people are cooperating, or what are the chances before and after exit or entry, how things are moving. But the clear aim should be to set a safety culture where people are not merely encouraged to work toward change, they take action when it is needed. And so there should be visible leadership commitment and open discussion on safety, and resources must be available. If hand wash stations are not available, naturally they will not be able to use the hand rub. It is for you then to advocate safety culture. Motivators can sometimes be education, performance measurement, having a competition, communication campaign, provision of resources, and leadership engagement. But challenges are that many persons believe that guidelines do not apply to them, not sure when and how it should be done, lack of social support, or the common terminology is that they are very busy. But you should take steps to motivate hand hygiene, because this has shown to be one of the most effective and the cheapest tool to decrease infection control. Now, taking the steps that were given to you, it's 10 a.m. on a Tuesday morning, and it's time for rounds of surgical rounds. It's your first day on the hospital IPC person. You decide to join round team to observe and get routine practice on ward. The physical layout of the surgical ward and the patient profile of the particular day are shown below. You could get this right. You could understand this without trouble. You can unmute yourself and say whether this is fine with you. See, the first question was, the medical student asks, I wash my hands once before the round. Isn't that enough? What is your response? Your response, tell them that she does not, and there's another person, nurse manager, tells you that she doesn't understand how hand hygiene relates to HAI. What do you tell her? So you tell her that while it is sensible to wash your hands at the start of rounds, this is not enough to stop transmission of microorganisms. and definitely not enough to stop them entering critical sites with infection risk to the patient. The 5 moment is a simple approach designed to ensure that hands are cleaned as necessary for patient and healthcare worker safety based on the risk of transmission. This is why it is important to clean hands at the right moment using the right methods. Healthcare worker touch patient object in their environment and equipment repeatedly during the course of this work. Because of this, potential pathogens can be picked up and carried on their hands, making it possible for healthcare worker to transmit microorganisms that can cause infection from one patient to another as they come in contact with patients and their immediate surrounding inside the patient zone. It is therefore very important to think about and perform timely, effective hand hygiene to reduce the spread of health-associated infections. The 5 moments of hygiene are: 1, before touching the patient, that is to prevent us carrying infection to the patient. Before clean and aseptic precautions, again to safeguard the patient. After body fluid exposure, it is to safeguard us. After touching a patient, again to safeguard us. And third, after touching patients surrounding, again to safeguard us from picking up multi-drugs resistant bacteria from the patient. And of course, if we are protected, then the benefit will be that the next patient we see will also be protected. So these 5 moments you understand very clearly.
Yes, sir.
All right, so we can move on to where the questions arise when the round start. Here is the round, nursing station. The patient in bed number 1 is pre-operative. The patient in bed number 1 is pre-operative patient. The round team perform hand hygiene at the sink before entering the patient of zone number 1. Doctor gives a verbal consult on prophylactic antibiotics ahead of surgery. The medical chart at the end of the bed is touched by the resident during the case review. The patient in bed number 1 is not touched. After the discussion, the team moves to bed number 2. Now, question number 1. Question number 1 is, should the patient be, what is the moment? No, after discussion, the team moves to bed number 2. Question number 1 is moment 1. Before the patient is touched, should hand washing take place or not? Please unmute.
Yes, sir.
Yes, sir.
Yes. Before a clean, in this case, there is no clean or aseptic procedure done. So
Yes,
there is no need for, this doesn't apply. Moment number 3, after body fluid exposure doesn't occur, so it doesn't mean after touching the patient was not touched. After touching patient surrounding, the resident has touched the patient surrounding, so the resident needs to wash the hands. Okay. Number 2. Patient number 2 has abdominal surgery yesterday for hernia repair. The medical student performed an abdominal examination. During the examination, the patient starts to feel unwell and vomits to the side of the bed. The nurse helps to clean up the vomit after ensuring the patient is stable. The rounding to bed number 5. Use the slider below to identify when it should be touched. So, what are the times when should hands be cleaned?
Before touching a patient.
One is before touching the patient, then the
Yes.
medical
Then
student
the
after touching the patient, one surrounding.
Yes, sir.
Relate to abdominal
1
exam.
and 3, sir.
1
After body fluid exposure risk there also.
That's right.
before.
Okay, so you understand so these are the questions that we need to address, and that will take care of hand hygiene. Now, finally, we move on to environmental cleaning. Can you see the slides?
No, sir.
Now,
Yes, sir.
so we're looking at environmental cleaning and disinfection, principles of infection transmission, and the role of environment in transmitting infection. The learning objectives will be describe the significance of microbial contamination of the healthcare environment, identify the role that environment cleaning and disinfection plays in patient safety, list factors that should be considered when implementing an environmental cleaning and disinfection program. So the organisms which are present in the environment are methicillin-resistant Staph aureus. Normally, Staph aureus stays in the nose. So when you touch your nose, it stays in the nose because it can survive high salt concentration. Since it can survive high salt concentration in the nose, since nose contains high salt concentration, it has a selective niche for surviving. So Staph aureus you'll find in the nose, Enterococcus you'll find in the intestine, Acinetobacter baumannii is present in dust. So depending upon how frequent the Acinetobacter baumannii is isolated, it will show how dirty the hospital is. Klebsiella pneumoniae and Pseudomonas aeruginosa are found in water and in plants. That is why flowers are not allowed. I repeat, not allowed into the hospital. So flowers should not be allowed into the rooms of a patient because they will transmit Klebsiella pneumoniae or Pseudomonas aeruginosa. And they survive for long periods. Acinetobacter will survive for 3 days to 5 months, Clostridia difficile for 5 months, E. coli for 1.5 hours to 16 months, Enterococcus for 5 days to 4 months, Klebsiella for up to 30 months. So all this will survive for long duration. And it's also, if the previous person had infection and we have not done terminal disinfection well, then new patients are at increased risk of getting infected by Clostridia difficile or with multi-drug resistant Pseudomonas aeruginosa or Acinetobacter baumannii or methicillin resistant Staph aureus, or VRE. VRE stands for vancomycin resistant and E. coli, vancomycin resistant enterococci. After 5 seconds of contact with bed rail or bedside table, healthcare personnel's hand culture were positive in 53% of occupied room and 24% of vacant clean rooms. This you can monitor anytime you go. You can take a few culture plates with you, and when you come across the surgeon, if you ask the surgeon whether their hands are clean, normally they would say yes, abhi to wash kiya hai. So if it is clean, ask them put their hand on the, especially the fingertips, they should place on the agar, gently on the agar, and then you label it with their name and get it back. Next day, you in the microbiology lab, it should be incubated at 37 degrees Celsius. Next day, you will find that many of these fingerprints are positive. But if they have cleaned with soap, with either soap and water or with alcohol rub, most of the bacteria will die. So this is to confirm to them that more than half the high touch surface are not effectively cleaned at discharge. If we improve cleaning and disinfection, the number of infections will decrease by at least 25%. Basic concept related to cleaning and disinfection is cleaning is removal of visible soil and other organic material from object and surfaces. Disinfection is a process that eliminates many or all pathogenic organisms. But sterilization is which kills all bacteria, including spores. So when you want to get rid of all microorganisms, you should do sterilization. If you want to decrease the number of pathogens, then disinfection will do. And if you just want to keep it like this, then cleaning is fine. Now, in disinfection also, there are 3 levels of disinfection. Low-level disinfection will kill most vegetative bacteria, some viruses, and some fungi, but cannot be relied upon to kill mycobacterium or bacterial spores. Intermediate level of disinfection kills vegetative bacteria, most viruses, and most fungi, but does not reliably kill bacterial spores. And high-level disinfectant completely eliminates all microorganisms except for a few bacterial spores. And this is next best to autoclaving. Spalding has tried to say what needs to be done when. If the material is going to come in touch with intact skin, like blood pressure cuff, stethoscope, high touch environment surface, low level disinfection is okay. If the object is going to touch and come in contact with mucous membrane, as endoscopes, laryngoscopes, respiratory therapy equipments, or vaginal spatula, then high level disinfection is required. While if it is going to enter normally sterile tissue or vascular system, then it should be sterilized. And among the low level, the disinfectants normally that are used are quaternary ammonia compounds, phenolic compounds, hydrogen peroxide, hypochlorite, and accelerated hydrogen peroxide. But there are some gaps. Among them, you find that hydrogen peroxide is one of the best. Many factors are considered for selecting of the disinfectants, and you must consider whether the staffing will accept it. The aim should be to clean the, one is it should be clear who will clean what housekeeping will do and what nurses will do, or what technicians will clean, and what solution will be used for cleaning, so that the roles and responsibility of especially high touch areas are clearly defined. And cleaning of non-critical areas is very important. And what you need to do is look at what is the susceptibility of the organism and what is the level of disinfection that you need. And daily cleaning of high touch areas must be done vigorously. Now, whether it has been cleaned, and you should chart out a strategy for the cleaning person and how to, what is the route to be taken, and should start with clean area and finally end with dirty area, rather than start with dirty area and clean with end with clean area, because then they'll dirty everything. So start with clean area and finally end with dirty area, and special precautions can be taken. It can be no-touch method, for example, UV light, which will kill bacteria which are suspended, or hydrogen peroxide mist could be used to lower the number. Then a checklist should be maintained to ensure that all surfaces are cleaned, that all areas of the hospitals are cleaned daily, and that record should be maintained. The responsibility of equipment cleaning should be clearly documented, and staff should know who's supposed to clean what. Non-critical equipment, again, it should be clear who would do what. You might want to do training of the persons so that they know what is their roles and responsibilities. An annual competency check should be done, successful attendance at monthly training, and pass written exams. Then you might want to do auditing. Auditing could be visual assessment or direct observation. And of course, in the recent past, there are ATP bioluminescence that is being made available.
Hygiena System Sure Plus is a rapid cleaning verification system made up of 3 components: the System Sure Plus luminometer, ATP cleaning verification tests, and SureTrend software. These components make the ATP cleaning verification system a necessary and valuable tool that contributes to a complete and comprehensive infection prevention and environmental services program. Let's take a closer look at the 3 components. The System Sure Plus is designed for convenient one-handed operation and is easy to navigate with minimal training. Inside the system is an advanced solid-state sensor that is robust, stays in calibration, and does not require yearly maintenance. Customize your System Sure Plus by programming departments, rooms, high touch point locations, and users responsible for cleaning, such as EPS personnel, directly onto your system. All Hygiena test devices are designed to be easy and ready to use right out of the box. Efficient design and robust chemistry enable long shelf life and room temperature storage of the low-cost devices. With ATP cleaning verification tests for surface and water samples, the system is adaptable for a variety of applications in multiple departments, such as infection prevention, environmental services, sterile services, endoscopy, and dental departments. SureTrend software provides invaluable access to preset and customizable reports, sends automated emails with your favorite reports directly to your inbox, and consolidates data from multiple departments or facilities so you can easily analyze trends and identify problem areas. SureTrend also makes it easy to monitor cleaning programs, engage team members with valuable feedback, and improve cleaning processes. In fact, studies show that implementing a monitoring system to validate cleanliness can increase cleaning compliance by 42%. The System Sure Plus, ATP cleaning verification tests, and SureTrend data analysis software promote team collaboration towards a cleaner facility, minimizing the risk of environmentally transmissible infections. With technical staff and distributors around the world, Hygiena products come with
So what to test can be, you are looking at which surface has been cleaned and which has not been cleaned, and that ATP, whether if ATP is present, that means cell was present and that has not been cleaned. For best results, it's best to follow the best practices for environmental disinfection, properly train and educate environmental service technician on proper cleaning and disinfection process, have nursing, respiratory therapist, infection preventionist, and environmental services agree upon a list of equipment that are to be cleaned and disinfected by nursing and environmental services, audit cleaning and disinfection practices, and provide feedback to environmental service technicians to ensure proper disinfection of surfaces. Using a quality improvement approach, a problem can be solved, and there we will know a need to prevent pathogen transmission, need to prevent patients and or staff illness, need to reduce burden of illness in a particular area. And why we are interested in the process is we want to improve, we are interested in improvement, we must improve the processing, and we should do performance is improved by performing PDSA. PDSA actually stands for plan, do, study, and act. And this is how we improve the process. Now, finally, we'll come to the last where you would like. The final session now is to get your doctors to agree. So, roadmap for zero hospital-acquired infection. As you know, Hippocrates initially said that the first duty was that we do nothing wrong. We do no wrong. It was then a nurse, Florence Nightingale, who brought to the notice that in our attempt to do well, we are doing harm to the patient by causing infection. And it's been suggested that in America, where data is clearly available, more than 1.7 million healthcare infections occur every year. The healthcare infection, which can be considered as a mistake, occurs so frequently that it is equivalent to deaths in America because of healthcare infections are equivalent to one fully loaded jumbo jet crashing and dying everybody dying there every day. Now, healthcare associated infections, as I said in the beginning, consist of urinary tract infection, surgical site infection, pneumonias, and blood infections. That account for 80%. And as we also indicated in the beginning, many of them are preventable and preventable using a bundle approach. Infection is a chain. Infection from one person to another occurs as a chain reaction. From infection starts with reservoir, then there's portal of exit, then there's mean of transmission, port of entry to a susceptible host, and then it gets infection again. So as the ladies in the group will understand, the chain is as strong as the weakest link. So our aim is to break the link. The transmission can be direct by physical contact or indirect. In the community, it is through the air and through the insects and from bad water that infection is transmitted. In modern hospitals, because of the excellent infrastructure, inside the hospital, the transmission is not possible by these microbes, but this is replaced, transmission is replaced by the hands of healthcare workers, and hands of healthcare worker act like flies or act like vectors transmitting infection from one person to another person. In the past, our approach was to name, blame, and shame a person. But it indicates that if a system has mistakes, then we will always pick up mistakes. So nobody will be able to do everything right if there are mistakes in the system. So what is required is to fix the process. A process, medical error is a failure of process. Process means that something goes in and an output is obtained. In this, normally we have a tendency to blame whoever is making the mistakes. But the mistakes may be occurring because of policies and procedures and regulations and systems that decision makers have put in place. So it is not the sweeper which is at fault, but the CEO who has cut money to be given for cleaning up the waste. So one strategy has to be that whenever you're dealing with a very serious problem, then between the trigger and the target, you should put multiple barriers. This is known as Swiss cheese respiratory virus pandemic defense, so that there are various barriers between the trigger and the patient, so that one of them will hold the infection back. Hospital-acquired infections normally are 4: surgical site infection, urinary tract infection, pneumonia, and bacteremia. This accounts for more than 80%. And Staphylococcus aureus, E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, and Acinetobacter baumannii account for 80% of infections. To control infection control, we need 3 things. One is management support. Second is resources and involvement of staff. Staff involvement is very important for any activity to start. And we should target 0 preventable infections, and we should have 0 tolerance for healthcare infected infections, which are preventable and as a consequence of inappropriate practice. For that to happen, you must make available what is the right practices to be done. And I hope that attending this workshop has given you steps to put infection prevention and control in place, which is suitable for your location. Because if you adapt it to the local needs, you would be more likely to succeed. I think I will close at this and again say that if there is any question, if there are any questions that you would like to ask, please feel free to ask. I understand that some of you had to leave today, but in case there is something that we can do, please don't forget to get in touch. Okay? You can unmute yourself. Okay, then that is all today.
Okay, sir. Thank you. Dr. Kumar, you have any questions? Dr. Neetu? Anamika? Anybody has any query?
No, ma'am.
No. Okay.
Oh, ma'am.
Okay, thank you so much, sir, for the session. Now you people can leave the session, right?
Okay, thank you, ma'am.
Thank you. Thank you. Ma'am.
Thank you.
Thank you. Thank you very much.
Thank you, ma'am.
Thank you.